He might be talking to the other person.
चेहरा तो हमारी तरफ ही है। नीरज
He might be talking the chairperson, other chairperson.
अच्छा स्टार्ट करते हैं डॉक्टर नीरज। आप म्यूट पे हो नीरज।
हाँ जी सर, हाँ जी।
So, good morning, all the friends, all the faculty members, all the delegates from IIP Delhi. I'm Dr. Pankaj Garg, President of IIP Delhi for the current year. And it's my proud privilege to say that IIP Delhi has been in the academic forefront for the whole year, and every Sunday is dedicated to master class on one of the specialties. And this time, right now, we are going through, and actually, we're in the middle of pediatric cardiology master class. Last Sunday, we had an excellent discussion on the bradyarrhythmias in children, and today is the turn of tachyarrhythmias. So we have an excellent session lined up, which is going to be held by Dr. Midul Agarwal, who's a very senior person in pediatric cardiology section of Sir Gangaram Hospital's Institute of Child Health. And we have Dr. Neeraj Agarwal, who's the coordinator of the program, along with Dr. Midul. And I will also welcome Dr. Sanjay Khatri, who is the chairperson for the day, and Dr. Sham Meena, who's secretary of IGP Delhi. So I request Dr. Sham Meena to say a few words, and then I hand over to Dr. Neeraj for proceedings. Dr. Sham, sir.
Hello, good morning to all. On behalf of IIP Delhi, welcome to our all chairperson, Dr. Sanjay Khatri, Dr. Saraj Chandra, and welcome to our young dynamic cardiologist, Dr. MRIDUAL Agarwal, as a today's speaker. And thanks to, as usual, Dr. Neeraj Agarwal taking the lot of the pen for this program. Over to sir.
Thank you, Dr. Meena sir, Pankaj sir. You have been, instrumental in this program, and I am lucky to have this program to be coordinating. I invite Dr. Khatri sir today, chairperson. He is our close friend from 40s days, and we were together for some time in 40s also. He is very good academician, takes interest in PG students, in training programs, and currently he is a pediatric cardiologist in MGM Jaipur. We were together in 40s for some time. He was a pillar of strength of pediatric cardiology in 40s. Dr. Khatri, please say a few words. We want to hear you.
It's my honor to be on this platform with Neeraj and Mridul and IIP Delhi peoples. It's my honor. I am eagerly wait for listen to the Mridul, so we can start Mridul straight away.
So Dr. Mridul is, has been with me for years. He joined us in 2012, Gangaram, 13 years together we have been. Now he is senior consultant pediatric cardiology. He takes deep interest in arrhythmias, neonatal arrhythmias, fetal cardiology, neonatal cardiology. He's also very good in interventions. We have been together, and a team works together in Gangaram. So he has been with us, strength of pillar. All ECMO programs, all ECMO initiations are done by under Dr. Mridul's understanding. So, our results have improved because we have been together for last 15 years. So that is our strength, and I invite Dr. Mridul to start the program. Thank you, Khatri, for joining us today. Thank you very much.
Thank you, thank you, thank you.
Thank you, thank you.
So should I start now?
Yeah, please start.
Yes, yes.
I'll stop the video so that it will be more seamless then. So I've structured this talk for pediatrician and for office practice only, not for pediatric cardiologists. So this is not an ECG class, so I will be discussing less of ECG and more of pediatric practice here. And today I'm going to discuss what is normal heart rate and what is fast, and advantage of knowing the mechanism, how we can treat better by knowing the mechanism of tachycardia. And principal focus will be on SVT because this is the arrhythmia which should be managed by a pediatrician and most of the time present to pediatrician, and they are more in contact with pediatricians, so I'm going to focus more on SVT and how we can manage this in ER and OPD, and little bit focus on adenosine, which is the one of the basic drug there. And if time allows, if we can finish this thing on time, then I can move on to atrial flutter and EAT. And in the end, depending on time, little bit on antiarrhythmics. So let's how it goes, and we'll go very slow. So what is tachycardia? And very simple definition is it's a heart rate faster than normal heart rate, but it's not as simple as it looks. So, sorry, let's move to. So Pulse has given a heart range there. So for newborn, the upper limit has been given as 205 per minute, and in infant is around 180. So that means anything below that cannot be called as tachycardia. And past this, they have given a range for sleeping heart rate also, which is actually very significantly lower than the awake heart rate. And that is also very significant. We don't give a focus to a sleeping heart rate, but they have given a range for sleeping heart rate. And we can see that for newborn, awake heart rate is around upper awake heart rate is 205, but sleeping heart rate upper range is 160. So what we can take from this? So if newborn's heart rate,
Sorry to interrupt you.
sir.
5 to 90 for adolescents from the previous slide.
Sorry.
Sleeping heart rate 5.
So 50 to 90, sorry, it has to be, yeah. Typo, sir. It is for sleeping heart rate is 50 to 90 for adult sleeping heart rate, and awake heart rate is 50 to 100. So that's a different range, and everywhere the sleeping heart rate is slightly less than awake heart rate. So when we can make a spot diagnosis of tachycardia, suppose a child comes to our OPD and a newborn with a heart rate of about 200 and infant if the heart rate of 180. So they're like that. So with that chart, we can, on a single examination, we call that child is having tachycardia, irrespective of whether child is feeding or slightly active or they were flying a while before. So that's the range given by a pulse. So what's the role of sleeping heart rate then? So sleeping heart rate gives a baseline cardiac autonomic tone. Autonomic tone means what's the sympathetic and parasympathetic tone in that child. And sleeping heart rate reflects the most of the time parasympathetic, because that increases during the sleep, and that's why we can expect a slightly lower heart rate during the sleep. And it's if the heart rate is persistently high and do not dip during the sleep, then you can expect that the child is having a increased sympathetic drive. And if the heart rate never drops, we can suppose we put a monitor, patient is on telemetry, and we can see it's do not decrease during the sleep. And then we can think about that the child might be having inappropriate sinus tachycardia or other type of arrhythmia like ectopic atrial tachycardia. Or more importantly, what we see in our pediatric practice is compensated heart failure. And sometimes this might be the only sign of cardiomyopathy. So these are the message we can take from sleeping heart rate. So suppose a question comes and neonate come with a heart rate of 180, whether it is tachycardia or not, and if it is present all the time. So if we go by a pulse guideline, 180 is definitely not tachycardia. So it is definitely within normal limit if the child is awake. And but it's still concerning. It's absolutely fixed. That means there's no change. Suppose a child comes with 180, we allow him to feed and little bit calm down and still check again. It still remains high. There's no identifiable trigger. The child is not crying. There's no fever. There's no stress. And even during the sleep and calm phase, it doesn't decrease. It is might be slight concerning because it is in the higher range. Sorry. And if we have a ECG there and we show abnormality, then definitely it is not a normal heart rate. But if 180 increases or varies with the activity, and this child is having some fever or crying, was feeding a while back, and slow, and when the child calm down and slows down, then it's not concerning. And if can still high, we can not sure about it, we can do the ECG and we can check whether the rhythm is normal. So if you can take what message you can take from here. I don't know, sir. So 180 heartbeat is actually not a tachycardia in neonates by definition, but if it is fixed, not changing during sleep, afebrile state, a calm neonate, and it has a normal abnormal evaluation, and if any finding in ECG is definitely abnormal. So there's another way to check the heart rate. There's a chart based. This chart based approach we pediatrician knows very well. We plot a growth chart all the time. So midline is median rate, and we expect a typical range within around the median. But if it is persistently above the 90th, 90 or 99th percentile, there should be always a red flag. So this is how we understand heart rate. And what message we can take from this slide is if heart rate is above that range, so for neonates is above 1205, above 220, we can think there's high likelihood of the supraventricular tachycardia going on there. But if it is definite above 250, there's almost SVT diagnosis or arrhythmia diagnosis is almost confirmed. But it is if it is less than 180, the chances of it being SVT is very unlikely. And similar to infant, if it is less than 180 again here, it is unlikely to have the child is having SVT. And in older children, if a child is having a heart rate of 150, is unlikely to have SVT. Why I'm giving this chart? So now in the era of the smartwatches and home monitoring, so patient who have a history of arrhythmia, a lot of time you can get a call that, oh, my child is having heart rate of this. Well, child rate is heart. This is definitely slightly looks very high, but if it is definitely less than 150 an older child, we can say definitely it is not SVT. We can check again after some time. If it is remain high, you can come to OPD or ER, but it's unlikely to be SVT. So this is how it helps these charts that if it is a range is significantly below what the SVT should be, there should not be any hurry to reach the ER room. So I want to know mechanism of tachyarrhythmia, why it is important. So there are three mechanisms of arrhythmia. First is increased automaticity, second is re-entry, and third is triggered activity. So increased automaticity has a distinct pattern, and it is due to the enhanced automaticity either from specialized tissue. Specialized tissue, when I say that means SA node, the atrial conduction pathway, the AV node, the Purkinje and his pathway. So if it is either it can be from enhanced activity from these specialized pathway, or it can be from the any non specialized tissue like atrial ventricle. So it can be enhanced normal activity automaticity, or it can be abnormal automaticity. So the specialized part of automaticity is that although it is abnormal, but it is still affected by the sympathetic and parasympathetic tone. So they have a slight warm-up phase, and when we start treating them, they have a cool down phase also, and they generally get affected by the manuals like if we calm down the heart, it will slightly come down. If we give some volume bolus, it will slightly come down. So all these things, even during tachycardia, affects this automaticity. So this is the one of the mechanism for arrhythmia. The second is re-entry. So we have to focus. This is very important. What our next slides will be. So re-entry phenomena means once a pulse is generated from SA node, it conducts to AV node and Purkinje fiber to the myocardium, and this pulse should die off eventually and should not continue. And what happens in re-entry, this pulse continues forever. So I will give one of scenario. This is a typical scenario of AVNRT, AV nodal re-entry cardia. So most of the AV node have a single pathway, which is a fast pathway. Almost 50 to 70% of population has only single pathway, but around 20-25% to 40% in different studies have a second pathway. So what happens in most cases, this pulse conducted through both, but by the time slow pathway reaches to the distal point, that point is refractory and it never get conducted. But if there is an additional focus and which reaches to a distal connection on a time, then that re-entry is established. And now we can see this pulse never dies off. So this is the phenomenon of re-entry. And for re-entry, that means we have to have two things. There should be a substrate. That means two type of pathways, parallel pathways should be there. and they should have a different characteristics, fast or slow or too faster. One can be faster, other can be slow, and there should be an inciting event which can change the dynamics which was previously established. So here we can see otherwise it was conducting normally, but once there was a abnormal ectopics was there, which was so time that it reached to a distal point at the time when it was not refractory. So that can cause a re-entry establishment. So basically, we don't have to go in detail of that. It is called macroentry, that means a larger circuit, and it can be a microentry, that means a smaller circuit. It doesn't depend on whether it is across the atrium or ventricle. The macroentry can be intraatrial also. So that means yes, re-entry established inside atrium can be microentry. And so just basically that if a circuit is large, it's called a microentry or macroentry, and if it's small, it's called microentry. And the final mechanism of tachyarrhythmia is triggered activity. First two we know very well, and this was usually in long QT syndrome. And this is action potential. We can see the bump in phase 2 and phase 3. And when there's increased calcium during this in the myocardium during this phase, will be extra activity and causes a typical toss or the pointers type of arrhythmias. And the second type of trigger activity, which is due to the digoxin toxicity, and this is called due to delayed after polarization. I will not go to the trigger activity in this presentation. So if we go through the different mechanism, we can see in re-entry. So AVNRT, I discussed even in the previous slide. There are two different pathways in AV node, and this was causing the re-entry. The atrial tachycardia, what we can say EAT or chaotic atrial tachycardia, that is predominantly because of automaticity, but can be because of very microentry. Atrial fibrillation, that is due to the multiple microentries in the atrium. That's why there is a variable conduction, because when there is multiple circuits, sometimes one circuit get conducted, sometimes other circuit get conducted. So there is a variable conduction and variable rate. And then we can going to discuss AVRT in detail. Atrial flutter, there's a macro reentry within the atrium. And they also have single circuits, so they have very regular but rapid heart rate. Again, multiple atrial tachycardia is because of multiple circuits. So again, they have variability there. So these are the more common arrhythmia we see in pediatric age group. And where there is single circuit, that is very regular. And when there is multiple circuit, it become very irregular. So if you see irregular part, we have atrial fibrillation and multiple atrial tachycardia, but other four are in the category of regular. So what is the advantage of knowing this mechanism? So if there is increased automaticity, the beta blockers works very well because it acts on sympathetic drive, and because these are affected by sympathetic drive, they works very well. Similarly, in re-entry, again, beta blocker works here because it changes the conduction velocity of the pathway. But other drugs like flecainide and calcium channel blockers also work very well in this patient. In fact, in adult age group, now these are the preferred drugs, the sotalol, flecainide. And triggered activity, again, we know long QT syndrome, we have to start beta blocker in almost all the patient. But the triggered activity with due to other mechanism, we need a membrane stabilizing agent. So propranolol is not only the beta blocker, it stabilizes the membrane also. And other drugs like lidocaine and edinodron also act in this condition, and magnesium also. So automatic arrhythmia responds best to the rate control with beta blockers. Re-entry circuits requires a blockage of conduction pathway or increasing the refractory period. And trigger activity involves the calcium overload or repolarization delay. So we have to aim at the stabilization of the membrane and increase the repolarization rate. So once we have an ECG, how we can detect what could be the mechanism? So simple two, three step.
Dr. Mridul, you are not audible.
So it's hang on actually.
Yes. So Dr. Khatri, till he rejoins us, how do you manage your patients in ICU? when you see a patient of arrhythmia, do you
Yeah.
go for the mechanism or do you start a medicine even if you don't know the mechanism? What is the common practice you do practice in your ICU?
In ICU, generally, we first or second day, sometime when the patient is sick, all the strappings are there. We manage only by the seeing the monitor, and we always try to take a 12 lead ECG properly. Because when you talk about the mechanism, you need a 12 lead ECG. Sometime in the first, second day of life, it's not possible because the post-op patient TGAs are chest open, TAPVC, PH are chest open. So we just concentrate on the monitor with the various lead and accordingly try our medicines what is suitable for the patient to control the tachyarrhythmia. But yes, when patient is stable, it is my message, always take 12 lead ECG before starting treatment or commenting the type of arrhythmia. 12 lead ECG is very must to proper proceeding for the arrhythmia. But in ICU, sometimes you can understand, Neeraj, it's not possible always to take 12 lead ECG because patients are hemodynamically unstable. So we generally monitor with the, whether it's a jet or it's a SVT, we generally monitor with the monitor only.
Yes. So, sir, like suppose it's not post-op patient in the NICU or PICU.
Yeah.
De novo patient, like mostly you talk about NICU,
Yeah.
you commonly see SVTs, commonly
Yeah.
see SVT.
Yeah.
What is your primary choice of drug? How do you decide like you use beta blockers, digoxin or
No.
Tomadron?
No. So it's a patient is on clearly SVT, which proved by with ECG. So first I give adenosine and I make my resident, they should know how to give adenosine, the proper dose, method of giving adenosine. Adenosine is the harmless drug. Every PG resident should know how to use adenosine. So if arrhythmia control with what adenosine, it's okay. If reoccur again, I give adenosine. If again reoccur, I take the patient on generally on amiodarone by doing T3, T4, TSH before starting the amiodarone. Or if patient is not occurring again and again and I want to discharge the patient, I generally discharge on the beta blocker. But yeah, this is for a stable patient. But sometimes NICU patients are not stable. Their LVEF is when they presented to us in the NICU, EF is 10% only because they have a fetal SVT. So now they come to us for 10 days, 12 days of life with LV dysfunction. Yes, I first give the shock to the patient if patient is unstable. Patient is unstable. In my experience, if it's a fetal tachycardia, fetal SVT, when presented in the neonatal period, it's very difficult to control with the single dose of adenosine. Sometimes we give adenosine repeatedly 10 to 15 times in a day. We started amiodarone, monitoring of QTC, sometime not hesitate to start flecainide also. But yes, constant QTC monitoring is there when you start two antiarrhythmic drug in a neonate. Yes, because as you know, Dr. Neeraj, when SVT is resistant, when you start from the fetal, so it's difficult to control. It takes few days to control get the sinus rhythm. But yeah, the early indication when child is continuously having SVT. But if we abort the rhythm and rhythm remains sinus for few hours, we say few hours, then definitely LVF will increase. And that is quite satisfactory that we are going on the right line. So I always tell my resident, don't hesitate to give adenosine. You should know how to give adenosine, proper dosing of amiodarone, proper side effect of amiodarone, and monitor the child. This is our practice, Dr. Neeraj.
Yes, sir. So what we do in our NICU, Dr. Pankaj is also around. Normally we give adenosine, and if it's controlled by single adenosine, normally we start beta blockers. So our choice is beta blocker most of the times. But if, as you rightly say, if it's resistant case, like having repeated SVT, then we switch over to amiodarone. So, and also we all have to understand, amiodarone takes time to be effective.
Yeah.
Doesn't work very rapidly. So do you give bolus also? Like normally we avoid in our ICU, we avoid bolus
No.
because we're worried about hypotension. But do you give bolus?
Yeah, generally we give the bolus for 4 hours, then maintenance for another dose. So bolus is just 15 microgram per kg per minute, followed by 1 to 5 microgram per kg per
4
minute.
hours, not half hour. 4
No,
hours.
no, 4 hour. 4 hour. Bolus is spread over 4 hour actually.
So that's what we do. We are always worried about to give to half hour actually.
Yeah.
We give for 4 hours. That is true. High dose for 4 hours and then reduce the dose as per heart.
Generally we do the T3, T4, TSH before starting the amiodarone, because in rare case, in few cases, I saw derangement of TSH later when the patient is on oral amiodarone for a long time.
Yes.
So
because
Mridul
we
is
are
back.
doing newborn, because we are doing newborn screening, so TSH is already done before the patient gets into this.
But sometimes it's outside patient, na?
Yeah,
It's
then
not,
it is. Yes.
then
yes.
it's necessary to do the
Correct.
TSH. It's
Correct.
So
But
Dr.
Mridul has joined. Huh.
Let us restart the
yeah.
session.
Mradul, you are muted actually. Unmute yourself.
Yeah.
Yeah.
Now you can hear me well. So we are reaching a point that we are seeing the ECG of sinus tachycardia, and a lot of times it's not easy to differentiate between sinus tachycardia and SVT. And one of the important clue we can get from the history, sinus tachycardia builds over the time, and we can see if child is there in the ER for half an hour to 1 hour, you can see if have not given anything, it has increased over the time and it changes with the fever. If child is crying or feeding, it increases. If child calms down, it decreases. Whereas as in case of SVT, whatever we do, it doesn't change at all. That means if we calm the child, still the rate will be almost same, varying just by 1 or 2 number. And the rate variability is not there because it's because of re-entry, and that speed of re-entry remains the same. And if you decrease the temperature also, it doesn't changes. And if you are lucky, we can see the P wave in sinus tachycardia, and sometimes with very fast heart rate, it's not possible. So it's a common case scenario. 2-month-old child with a poor capillary fill comes with tachycardia, and this was the ECG. So first we go through the rate. It's a regular narrow complex as we go through the chart. And if we want to see the rate, it was almost slightly one more box than 5 boxes. And then rate will come down around more than 250. And we do not see any P wave directly. But if we focus on V3 there is a small deflection in the T wave segment and there. And so this is a retrograde T wave. If we can see that it is SVT, but if we you can recall the initial slide, if the heart rate is above 250, the chances of it being the SVT is very high. So unless proven otherwise, it's at sinus supraventricular tachycardia. And although it is called as supraventricular tachycardia, it is not generated in above the ventricle. It is ideally should be called paroxysmal reentrant tachycardia because it is a paroxysmal in nature and it enters a phenomena. And it is most of time, not most of time, it is a atrioventricular tachycardia rather than supraventricular tachycardia. But it is a misnomer it is used. So it is the most common arrhythmia in children, and prevalence is around 1 in 250 to 1 in 1,000 in different studies. There are 2 peaks. Highest peak in neonatal and infantile age group. Then second peak is around 6 to 7 years of age. And 40% of these patients present in first month of life, 50% in first year of life. And instance of heart failure in infant is 30%, but in older age is practically non-existing. So SVT in age or significance of age in SVT is very important because on the basis of age, we can divide the presentation and management in 2 groups. Early childhood, that is neonatal infant, and early childhood where child cannot communicate well about the palpitation, and then grown-up childhood where child can communicate somehow that something going wrong. So we can divide in 2 groups. Definitely it can be AVRT or AVNRT in this group. And again, AVRT is more common in much more common in pediatric age group, almost 80% of in neonatal and infant, and even the older kids, it is the ratio is slightly very higher in AVRT. That means presence of aberrant pathway. So what happens in AVRT? There is the presence of additional conduction across the atrial and atrioventricular system. So
I'll interrupt you for go back to 1 or 2 slides about the mechanism, like one side back, one more. Sorry. So yeah, this one okay. This one okay. So when the patients comes to us, Khatri is also around. When the patients comes to our OPD or ICU, lot of parents ask us, मेरे बच्चे में क्यों हो रहा है? What is the mechanism in my child? What are the common causes? And lot of people send to you for RFA. इसको EP करा लो, RFA करा लो to find the mechanism. How many times you want to do RFA? Dr. Khatri's opinion is also taken, Mridul. Dr. Khatri's opinion also. How many times you think of doing EP in a newborn child to assess the mechanism of SVT? Dr. Khatri, you're around? We can't. I think you're muted.
Yeah. So in newborn, hardly we advise the EP study because unless our medical management fails, sometimes it takes weeks to control the resistant SVT which started in the fetal. So generally, the indication for RFA is only if your medical management fail and child becomes symptomatic again and again. In newborn, even in infancy, I will say never. 3-4 year child, yes, those child who recover from the SVT and gradually on the medical follow-up, despite they are having frequent attack of SVT, then we advise for RFA. Else, that all the mechanisms are very much clear. If you have a good 12-lead ECG, sometime Holter will guide you regarding the mechanism. But for diagnosis, radio frequency, generally we don't do.
Yes. So we also don't do. Dr. Mridul, what is your opinion about this EP study in newborns?
So actually, it is a part of presentation later. I think I will cover that thing.
Okay.
But yeah, I will cover this thing, that thing also.
Okay.
So I will go through the mechanism. So what is happening in AVRT? There's additional pathway between atrium ventricle, and in the beginning of when there's a beat is generated from SA node, that beat in initial phase, because this SSC pathway, they don't have a decremental conduction. That means they have a slightly faster conduction. So a part of atrium ventricle get beat directly from the SA node very fast, but Purkinje phase system is really conduct very fast. But before it can, this pathway can completely depolarize the ventricle, the Purkinje system catch up and it depolarizes the rest of the ventricle. So that's what we can see on ECG, that there will be initial deflection because it is almost like starting like a premature beat, like it was conducted from one side, so there's initial deflection like almost like a PVC, but by the time it reaches to a part of ventricle, the Purkinje system catches up, and there will not be a complete white complex. So initial part is almost like PVC, and rest of part is like almost like normal ECG. So it's overlap of the two things, because a part of the ventricle is conducted, is depolarized by the Brent pathway, and rest of the ventricle is depolarized by the normal pathway. So this is called a delta wave, where there's a white QRS complex there. I will come to this thing again. So what happened in SVT? This pathway is there, and most of the time when there is pathway is there, and we can see most of the time there was only a part of conduction, and if there is a well-timed premature beat is there, which got conducted first through the AV node and came back to the AV node again. So for causing AVRT or SVT in any child or any person, there should be two components required. There should be a pathway. Like that means ectopic cannot cause an SVT unless there's a pathway. There should be a substrate there, and a well-timed stimulus should be there. So a lot of time we see someone has put a PIC line, someone has put a center line, or during our cardiac catheterizations, patient develops suddenly a SVT. We have not caused any damage. We have just given a timed stimulus in those cases. That means we are not the culprit that patient has gone in the SVT. We have just revealed a concealed pathway there. So for causing SVT, there should be an additional pathway there. There should be a well-timed stimulus, and that stimulus is such well-timed that the accessory pathway was non-refractory and the wave got reflected back. So for causing the AVRT, there should be a pathway is essential. And when it comes to neonate, there are two spectrum of presentation. Although it looks unlikely that SVT patient should present very stable incidental detection, but in studies has been shown that almost 40 to 50% of neonates present as stable neonates, just came for a routine visit or for just examination, just for fever, for anything else, vaccination. So almost 40 to 50% of neonates come diagnosed to have SVT during the regular examination, and rest of them, almost only 30 to 40% comes in cardiogenic shock on CHF. And again, the management depends upon how the neonate is presented to us. So if there is a significant cardiac compromise, we go for medical management. That means we give IV adenosine, or if line is present, if we cannot able to assess a line and we cannot give the adenosine, we might have to perform the synchronized cardioversion. And if child is not is in poor perfusion, or there's no sign of shock, there's no hypertension, we can feel the pulse well, and child is really not very in distress. So first we have to consider vagal maneuver in these patients before starting giving any shock or adenosine. So the vagal maneuver in infants commonly use ice. So ice is not like solid crystallized. It should be all in the form of slurry, so that the bag should be in well contact in forehead, eyes, and upper part of nose, not covering the air entry. And the second mechanism, which is well recommended, is the upside downing of infant. So if infant is stable, they is not fed very recently, sudden decreasing the head to down posture, it is a very effective maneuver in this thing. The other thing which is commonly used is gag reflex and the rectal temperature, taking a rectal temperature. So all these are vagal maneuvers. And if in a stable neonate, the vagal maneuver should be tried before even putting the cannula. And while putting the cannula, a lot of times that also causes so much of parasympathetic response. That also can cause sometimes the stoppage of SVT. So before giving adenosine, vagal maneuver should be tried in all infant. Ice thing is just that the crystallized ice should be a slurry sort of ice, so that it covers very well the forehead and the upside downing of the infant in stable infant. But effectiveness of all this maneuver in infant and neonate is only 20%. So it may work, it may not work, but should always be tried. So once SVT gone down, there could be two possible type of ECG. One is then which looks absolutely normal, and other one can be with the delta wave. So once neonate present to ER, the management is this pathway. This is one of the very latest publication given by AHA scientific statement last year. And why I have given this chart. So this is the regular management. We give adenosine 0.1 mg per kg and increase to 0.2 or 2 and then 0.3. And if there is a termination of SVT, then we go for the further management. And now this time they have included the dexmedetomidine in this pathway. Although we have never used dexmedetomidine, but they have included based on the multiple studies. And dexmedetomidine can be given 1 microgram per kg over 20 minutes. Esprolol is very useful drug. It can be given and it helps a lot. And eventually, if nothing works, we go for amidron, sotalol, or cetalol. The availability of procainide is the issue. The rest of the drugs are available in the market. So once SVT got terminated, whether by a vagal maneuver, whether by the adenosine or amidron, what to do next? So first we have to assess whether the presentation of the infant was stable or was in failure, and if there is any sign of cardiomyopathy or on echo. That is, if the child was in tachycardia for a very long time, then the child might have developed some cardiac dysfunction. So in ECG, we look for whether there's a WPW pattern, like we had discussed the delta wave. Echo, we have to do in echocardiogram to rule out structural heart disease or ventricular dysfunction. And we have to send a basic labs like electrolytes, thyroid, LFT, RFT. LFT, RFT is important. Suppose we are giving amidron or digoxin also. So digoxin get excreted by renal mechanism. So if you are planning to give long-term digoxin, KFT is also important. So after stoppage of SVT, there could be two possible ECGs. One which looks completely normal, and another one which looks there is a delta wave there, and which is a slurring of QRS complex. And when there is a delta wave there, we call it a WPW pattern, and which is there's a short PR interval because early initiation of part of ventricle depolation of ventricle, and because of early depolation, the QRS become widened. So when there's a delta wave pattern, we call it a WPW pattern. And when this child have a symptomatic arrhythmia there, we have seen episode of arrhythmia, then it called WP syndrome. So for WPW syndrome, there should be a WPW pattern. and definitely at least episode of symptomatic arrhythmia. They are to call it a syndrome. So discharge medication, these are the usual discharge medication, which is include propranolol, which is a beta blocker. This usually is a first line mechanism. Second is digoxin. Lot of time flecainide is given. It has incidence of use of flecainide has increased and is proven to be very effective. And amiodarone is given, especially when it required during the initial phase of SVT. So there was a trial long back which has shown the effectiveness of digoxin and propranolol is almost equal, and that's why still the digoxin is not an unfavored drug. An advantage of digoxin is it has syrup formulation available in the market. It is very easy to give, and it has very low incidence of side effects in pediatric age group. And only thing we have to remember that it should not be given in renal impairment. So if the child develop dehydration or renal impairment, then we should be cautious in this. So digoxin is a good useful drug for long-term management. And the propranolol is the most common drug otherwise used, and it is effective in all type of SVTs, and it's safer in WPW. So starting dose of propranolol is usually 0.5 mg per kg per dose, and should be given at least 8 hourly. So what we have to, sorry, Nilka. So this was again from the mechanism only. So after termination of sinus tachycardia, if there is no pre-excitation, we can give both either propranolol or digoxin. If there is sign of pre-excitation, digoxin is usually not preferred in these cases. So after termination of SVT, if we can see delta wave, we should go always for propranolol. And if it is no pre-excitation, we can go for either propranolol or digoxin. Both have similar efficacies. If you can see the parents are educated enough which can break the tablet and give accurately each time, we can go for propranolol. But if we cannot understand that they will not able to give, we can go for digoxin also. So on discharge planning, we have to take care of few things. We have to, importantly, we have to teach them some basic vagal maneuver. Suppose they are living far from the hospital, and we have to give some symptoms where they can assess whether this recurrence of SVT is there or not. So if there is poor feeding, lethargy, respiratory distress, poor distal perfusion, that means cold feet, and decrease in urine output, and decrease if the child is not responding well. So these are the common signs. If there is combination of more than 2 or 3, the chances of SVT is there, then they can go nearby ER and they can get the pulse of the child checked, and if it is high, they can bring to the ER. The most important thing we have to tell them, the parents, that suppose a child developed SVT, is not like child is going to have a cardiac sudden cardiac death or something. That most of children, even in neonates, they tolerate the SVT very well. After initiation of SVT, the symptoms usually occur after 8 to 10 hours after the reinitiation of SVT, not like immediately. That means if the child reaches to our ER with SVT, we don't have to rush for crash cart or everything. We can plan out easily. We can put an IV cannula, we get an ECG done, so that we can manage easily. That not like it is a dire emergency that a child is going to have a certain cardiac arrest there. So it takes a long time for child to develop symptoms in case of SVT. So once we started, how long we going to continue all those things? So once we discharge, we call them back again after 1 to 2 weeks and review an ECG, what's going on there. If child is on amiodarone, we check in QT interval, whether it is in range or out of range. And then we plan 6 to 8 week visit every first week for 6 months. And in intermittent, we do halter just to check whether there are some unnoticed SVT events going on. If child has presented with poor cardiac function, we check an echo also on follow-ups, and then after every 3 to 6 months in initial days till the heart function recovers completely. So when to consider stopping cardiac medication? So there are a lot of controversy, and it is really developing in last few years. So there are most of the time it should be continued for 6 to 12 months. That's what we are following yet. And if in case of it should be followed to 12 to 6 to 12 months in case of normal ECG and echo, and if there is no WPW and no high risk features. So why the presence of WPW is important? In the presence of SSV pathway, it can so what is happening there in SVT when there is no WPW pattern? That means the SSV pathway is not conducting forward because the the white QRS complex was generated because of disconduction. So this pathway can conduct forward only or go in both direction. So if it is not conducting forward, there will not be any white QRS complex pattern, delta wave pattern, but it is still there and it can conduct in reverse direction. So this pathway can cause SVT, but will not be present in the surface ECG because there is no forward conduction there. And advantage of this thing when there is no for delta wave in ECG is that when there is an arrhythmia in upper chamber, it will not get conducted through this pathway. So these pathway where there's only forward conduction, they have lesser risk of other arrhythmias getting conducted through aberrant pathway. And that means a child developing or person developing spontaneous atrial fibrillation will not be converted to ventricular fibrillation because there is no forward conduction through the aberrant pathway. That's why the management of the person with integrate pathway or absent of integrate pathway in AVRT is different. So there are depending how long we have to continue. There are multiple trial. One trial has shown there is no difference between the recurrence when for 6 months or 8 or 12 months. And this is a very recent study. And this has shown that even initiation and non-initiation has not changed anything. That means what they have two arms. One there is pharmacological arm, and where there's only education and observation was done. And this is very good number for SVT 64. And what they have seen, the recurrence is slightly higher in pharmacological arm and lesser in the non-pharmacological arm. And eventually, overall emergency presentation is slightly higher in pharmacological arm and lesser in education arm. And this is the second part is mainly because there's lot of stress on education in this arm, and the parents are taught that SVT is not emergency, how to treat that with vagal management at home. And because of that, if the SVT breaks in next 3 minutes or half an hour, 1 hour, the parents usually do not reach at emergency. So after this article, there could be a recommendation in future that long-term prophylaxis might not be required. But at current, we are giving the prophylaxis at least for 6 months. We reassess at 6 months if there is no ECG problem and parents are ready to check the regular in the child regularly. We can stop the medication at 6 months. So when 2P, there should be a high threshold for initiation medication when there was hemodynamic instability at the time of presentation, and there was a WPW in the ECG. And if the child was having recurrent episode during the first admission or during the initial period, and this underlying cardiac structural defect and dysfunction, and if there is a history of sudden cardiac death in the family, that means this SVT might be associated with some channelopathy. So in those cases, there should be a very high threshold of continuing the medication for a long time. And there should, so this recent guideline, which was published last year, they also have stressed on education. I don't know how much it is possible. They given that auscultation should be taught to all parents, and it should be done few times during the day. But still, we are not going through this recommendation, which was given last year. And when to refer, and when there is when to refer to a pediatric cardiologist, when there's recurrence in spite of medication, when there's sign of cardiomyopathy during presentation, when mechanism is not clear whether it was SVT or flutter, and when we are suspecting there's WPW or white complex tachycardia there. So if a child of SVT presents with bronchospasm, what to do in emergency? Whether we can give beta agonist like albuterol or salbutamol or terbutaline or not. So most of cases we can give if there's a recurrence of SVT should be treated, but the preference should be given to the bronchiolitis management. And again, if the other way around, if child of known bronchospasm present with SVT, how we treat, we go through the vagal maneuver first in these cases, and then only we try for adenosine. And recommendation is that the dose of adenosine, the initial dose of adenosine should be reduced. Usual dose should be 0.05 microgram milligram per kg in these patients. That because adenosine is known to cause bronchospasm. And prognosis is very good in cases of neonatal SVTs, and almost 70 to 80% may have spontaneous resolution, and only one third. So usually rule of one third is there, because so one third may not have any episode after that. One third, additional one third will get resolved during the first year. Only one third remains, which can have a recurrent episode afterwards. So that's how it works. So only one third of the patient who had a neonatal SVT can usually have recurrence after the first years of life. They have very good long-term prognosis and very low mortality. So any questions so far?
I think
Mridul, just one question. You prefer propranolol or metoprolol? Because metoprolol is a cardiac selective. It's not act on the bronchus. So it's good now. Why propranolol? Because, and second question, what advice you give to the patient if your patient of SVT who is not in SVT recover, if have developed cough, running nose, what medicine avoid or what medicine he should take?
So first, I'll say the metoprolol is not that cardiac selective, that it still works on airway, but propranolol has multiple advantage. It is not only a beta blocker; it's memory stabilizing agent, and in a pediatric age group, the propranolol proven to be works better than metoprolol. So definitely in first year, it should always be propranolol. After first year, metoprolol can be tried, because metoprolol again is advantage is there that we can give 12 hourly. Propranolol we have to give 8 hourly. So slight difference. So either drug we cannot give once a day. Both of drug we have to give at least twice a day. So that advantage is not there in most of the case. In our older age when we use the coated tablet and extended, so seconded in coated tablet can be once a day. So that those patients can use metoprolol, but metoprolol does not have significant advantage of bronchospasm. So atenolol is known to have a less bronchospasm, but atenolol is not proven, very well proven antiarrhythmic drug. So it's still not given in most cases. Second question, I forgot what it was.
Second, we write avoid sympathomimetic drugs for
Yeah,
SVT. So whenever
yeah.
cough is there, they ask what हम क्या दवाई शुरू करें doctor?
So lot of time we say that, see this mixed combinations of cough medicines, they have lot of time the decongestant, which can increase the atrial activity and generate the ectopics, which can precipitate the SVT. So that is there, but SVT again should have a timed ectopic to cause an SVT. So incidence is not that high like the EAT and other type of arrhythmias, but still it can cause, and that should be avoided in all cases, but especially in cases of SVT. And the second part I've covered, that if this patient comes with a bronchospasm, in those cases we should not hold up to the beta agonist. We should give beta agonist for bronchospasm first. If there is recurrence, which is actually not very common, even on albuterol, all beta blockers increase the incidence of atrial ectopy in all the children, irrespective of there is pathway or not, whether it get noticed or not. So that ectopy can cause SVT, but chances of that is not that high, which is what we think. So the priority should be given to bronchospasm than the SVT in those cases.
Good.
So, Dr. Mridul, please finish the case now. We have 5 minutes only. So finish the important parts and then we'll deal.
So I will continue wherever how much time allow. So then we'll stop where it is. So I forgot where were we? So adenosine, I will cover at least adenosine there. So adenosine is one of the drug which is commonly used, and indication is narrow complex tachycardia. It can be used as a diagnostic in wide complex tachycardia to differentiate between the VT and SVT with aberrant pathway. And it is not effective in tachycardia of lateral fibrillation or VT, but it can unmask the underlying atrial activity. So how to administer? We prepare. It is almost a must. There should be an ECG and crash cart present in the adenosine. Adenosine can terminate lot of arrhythmia, but it is a channel it acts on channels, and it is suddenly increase the calcium and potassium dynamics, changes the calcium potassium dynamics. So it can have the potential to cause VT. So there should be crash cart present nearby at least. And the typical dosing is first 0.1 milligram per kg to a maximum of 6 milligram, and second dose can be increased up to 0.2 milligram to 12 milligram. This we all know that all adenosine should be followed by a rapid bolus. So the two syringe method is commonly used, and this is one of the video which can demonstrate how it is should be done. So there should be a three-way of stopcock method should be there. So stopcock and a syringe should be connected indifferently. The piston should be held backward, and we push adenosine. If single person there will push the adenosine from end while keeping the piston should not go into the syringe, and then flush the saline immediately. So this is the method, and immediately after flush, if it is SVT, there should be a long period of heart block, followed by a sinus rhythm. So this is two syringe method. Although last year when there one article published, it was in long big study, which is a lot of people there, and it has suggested that single syringe method versus double syringe method does not have a significant difference. And in this study, the actually single syringe method proven to be more effective, but we still are using the double syringe method. So, and adenosine has a very short half-life, 6 to 8 to maximum 10 seconds. It can cause few side effects like flushing, chest pain, bronchospasm. It can cause brief asystole. So this is looks very innocuous thing, and this asystole is very important in older children. So it causes very severe phobia. Older kid who has gone episode of which has received adenosine has a lot of phobia about adenosine. So it causes, although it looks very innocuous, it recovers very fast, but it can cause severe phobia and PTSD sort of symptoms in a lot of older children. It should be used with caution in asthma and WPW with atrial fibrillation. So if any sign of it, if it child is a known of case of atrial fibrillation or structural heart disease, and there's chance of atrial fibrillation, should use it cautiously because it can convert atrial fibrillation to ventricular fibrillation. And there should be resuscitation equipment present very close by. And so this is a part where I concluded the neonatal SVT. So if time allows, then only go forward. Doctor,
I think we can have the question answers and discussions. Dr. Khatri can initiate some discussion also.
I'll
So
just conclude to one part. Sorry, Dr. Khatri, एक चीज just I want to conclude.
Yeah.
What's the major difference between, I'll skip this slide, between the adult and the older children and neonatal age group? In older children, as the role of vagal maneuver is very high. So it is the first line of management, and almost the I will just go. So because I have seen lot of patients having 3-4 episode of SVT in a year and not knowing a single maneuver of vagal maneuver. So this is a slide. So most common advice vagal maneuver should not be given. The carotid sinus massage and eye massage is contraindicated in most cases because nowadays we know that lot of patients can have early carotid plaques. Carotid massage and eye massage should not be given. So most common maneuver is advice is this one. Take a 10 ml syringe, ask the child to blow as hard as possible for 15 seconds. So it should be as hard that almost child face should become red. So vagal maneuver should be taught to all older kids and all the parents. So I see a lot of parents, they have incremental dose of propanol on each visit, but they don't know a single vagal maneuver. So this is the one of the common maneuver. Give them a 10 ml, ask them to buy a 10 ml syringe, close the piston, ask them to blow through it for continuous, not just brief blow, for continuous very hard and for 15 seconds so that face become red. Then they release and it can revert it. This is called modified valvular maneuver. And what it does, we have to blow for 15 minutes, then immediately lower down the child from 50 to recline position and bring back after 15 seconds. And a trial has shown almost more than double chances of reversion of Valsalva with this maneuver. This is called revert trial. And this is the last slide before I conclude. And this is the one of the real I have captured there. So how it is done, it is you ask the person to blow, and after 15 seconds, they suddenly lower down the head and there's very high chance of reversion. And with this, and second thing we can touch is the ice to face maneuver. By very ice cold water, face to should be dipped in ice cold, and the final maneuver is headstand method. So child can be assisted to headstand, or they can do themselves by do handstand. And with this maneuver, we can see with the modified valve, almost 50% of SVT can get reversed, and even what maneuver can almost 40% can get reversed. So it has very high chance of reversal. So it should be very first step. Even after reaching the year, we should try once doing the vehicle manuals first before doing IV, taking an IV canva. Yeah, Dr. Khatri.
Yeah, Mridul, very nice talk. You cover all the point very nicely, which is applicable to all pediatrician and treating physicians. This you cover all the mechanism very well, all the drugs, what need to give, what not to give. And particularly, I like the vagal maneuver. This is the basic thing. Yes, I agree. This need to be taught to the parents. Now, my question, how frequently use the flecainide versus amiodarone? Your first choice is?
Yeah. So flecainide, yeah,
Although,
there's a start called fast trial before a few years back, which has shown that flecainide can cause VT in with cardiac dysfunction. So after that, so if the child present with refractory SVT, they usually have some cardiac dysfunction on echocardiography. So flecainide as a acute maneuver, I'm not using at all. But if a child comes with recurrent SVT on medication, this is a very good medication. Has very low side effects and can be used very well.
Actually, I have used in most in flutters. At the flutter coming to
yeah.
OPD, or but you admit them for monitoring actually for stopping the facility. Some noise is there from the.
So it's a very helpful, actually, in my practice, the most of the pediatricians or some physician refer me the ECG, those are sinus arrhythmia. Yeah, because they diagnose as a tachycardia, but what is the sinus arrhythmia? Yes, they are saying the waves are not coming regularly. So this is also one of the entity pediatrician should know, sinus arrhythmia. This is a normal phenomena. So
Yes.
everything you covered, Mradul, nicely. It's a very good presentation for all of those are attending. It's a good presentation. I think you have covered all the things. Neeraj, what will you
Yes.
say?
Yes. Thank you, Sadri Saab. Your opinion always and presence always matters to us. Really has been a good presentation. Dr. Pankaj sir, can we conclude remarks
I
from Dr.
think
Pankaj sir?
a very well presentation. I have a very general type of comment to make. Very recently, I think not even yesterday or day before yesterday, there was a news item when it was saying that use of the drug controller has made some observation that use of beta blockers like propranolol, metoprolol on a long basis have been implicated as leading to psoriasis and certain other adverse effects. So I was just wondering that in pediatric age group, we have been using these drugs for a very long period of time, like these propranolol and all for such a long. So do you feel there's any reason for this observation, or this is just adult phenomena only?
We'll go ahead. So, lot of propanol side effects of propanol is based in pediatric group is on hemangioma studies. It is very commonly used in hemangiomas, and it has shown the incidence of any small, even the minor side effect is less than 2%. And one of the most common side effect in neonates or pediatric age group is sleep disturbance. That means once you give start propanol, they start saying the child sleeps more during the day and not sure about night. They're never sure about night. So if you start propanol and they start complaining child is sleeping more during the day and they have disturbed sleep, that's one of the most common complication in neonates given for propanol beyond the cardiac complications. So cardiac complications are bradyarrhythmias and hypotension if the dose, because we have to break the tablet and mix the tablet, they have to give the tablet. So dose discrepancies are not very uncommon in neonates, especially because we have to give 1/8, 1/10 tablet. So that is there. But beyond that, sleep disturbance is one of the most common complications. Child sleeps, the complaint of child sleep during the day is not uncommon with propanol. And second is hypoglycemia. So if the child develops gastroenteritis on propanol, they should be advised if child is developing gastroenteritis, they might have we have to withhold the propanol. So that's all the only two complications have seen reported in studies. Dermatitis, psoriasis is not at all reported in any pediatric studies.
And what is the reason for getting these? For so many years, these drugs have been used, but still they are available as tablets, not available as syrups or drops or suspensions. So, any particular reason for that?
Stability of the propanol as in a liquid formulation is the main issue. So that's why it is not prepared. So that's why if we recommend that they have to dissolve in syringe, have to given, and then also we have to make it fresh every time. We cannot use the morning drug in the evening and that sort of thing. So that is the main issue. Probably that's why it is not getting. We are not.
We've spoken to few companies also, Cipla also. We have told them that at least for syrup form. But somehow stability remains an issue. They have been working on it, especially Cipla is working on it.
So, can we give the injectable the preparations as oral things like in
That
place
is
of
not
tablet?
No,
recommended at
no.
all.
Propanol injectable
While
is not available at present. So we are trying for.
like suppose metoprolol or something like that, which are available as injection, can same be given orally?
No,
No, not at
no.
present. Previously, people used to give Lasix. We are not never sure. We are what is drug administration is control advice recommending. We are not sure, but legal issue of this that which is not recommended. We can give if we give. Don't know what's the legal implication of that.
Of course, also efficacy and absorption, we don't know. The bioavailability, we don't know actually.
Okay, I think these are general comments by pressing neonatologist and pediatrician. So it's a hassle to give these small tablets in a very
Yeah,
diluted 1/8 format, and
You know, one
especially in
incident I
newborns and
remember,
younger
Dr.
infants.
Pankaj sir, I will interrupt you. When I joined Gangaram in 2011, one SVT patient was there. Viduru, you also may remember this patient, newborn. We gave adenosine, it recovered. We said it's only one episode, we'll wait. Doctor said, you know, start some drug. I said, nahi yaar, abhi there's only a single episode. And after 2 days, we sent the patient. The same day in the morning, he had episode. Then the family credit to 2 दिन से आपने कुछ नहीं किया है और आज फिर से हो गया मॉर्निंग में. So SVT is an issue, but we have to be like only scientifically we can go only. So normally still today also we don't use in a single episode, we don't start the beta blockers. We start only after second episode. It's a rare phenomenon to have a repeated SVT.
that is why the role of digoxin is still there. So if there is no WPW in baseline ECG, digoxin can be given if parents are really worried they cannot break the tablet in 1/10 and it is very difficult to give. So SVT without WPD baseline WPW in ECG, they can be on digoxin if they are really worried.
Oh, I mean, any drug, it is fine. Normally you don't want to start in the first episode of SVT. Any drug, either digoxin.
So thank you so much. I think I'll request Dr. Dinesh Goyal, our treasurer for IAP Delhi, to present vote of thanks and then conclude the session. Over to Dr. Dinesh Goyal.
Yeah, good morning, everyone, and thank you so much, Dr. Mridul. And it's a wonderful session, and you covered this topic very nicely. And thank you for the chairperson, Dr. Sanjay Khetri, and Dr. Chandra sir. And I just want to ask, how long we have to give the beta blockers after the second episodes? As Dr. Mridul said, 1/3 resolved over a time period. So how long we have to give this propranolol? After the second episode of SBT?
So the recommendation wise, so for 6 to 12 months, it is the recommendation.
Okay, okay.
So usually keep on follow up. There's no breakthrough episodes after at 6 months. There's no ECG findings. Parents are willing to take care of the child if there is any issue. Then most of the time we can stop at 6 months and check how child works. And if the child's parents are really still worried and had a difficult neonatal period, was cardiomyopathy, we continue for at least for 1 year.
So do we go EPS studies in every case or after the second, third episodes?
So I'm not able to reach that point, but EP study is actually not recommended in almost any SVT before the age of 8-9 years, because after 3 to 4 years, this become in the managing SVT become very easy. Child can communicate, the child is having SVT, and short-term SVT do not cause any harm to the child. They can reach easily within 1 or 2 or 3 hours to the ER, and they can get managed. And if they perform the vagal maneuvers, most of the time 50% to 60% time it can get resolved at home. So in those cases, they still not worried. So most of the time, early EP is not required in SVT in most cases. So if we go by society recommendation, 15 kg was recommended last year. There was no recommended came. So above 50 kg, it can be done very safely even at lesser age. But usually it is not recommended at all most cases, because SVT is actually very harmless sort of arrhythmia. It doesn't cause sudden cardiac death. It has a recurrence if the school and the parents all are involved in the management and they can manage well. It can be managed medically and without medication in most cases.
Thank you so much, Dr. Mridul. Wonderful session. And we hope we'll continue the next sessions also in the same way. And once again, I thanks to the all delegates who attended this session and all faculty. Thank you so much.
Thank you.